The outpatient nurse practitioner that works with the renal team. So I'm just going to talk to you about a few things. I came from the 12th floor when I transferred to renal, and I was like, oh, I did the brain, kidneys will be no problem. And then I realized how much the kidneys actually do. So just going to kind of do a general overview. First, here's a picture of our team. We just took an updated picture this morning, so not all these people are with us anymore. But starting all the way over is Dr. Newmeyer. She's also in that CICU. Dr. Hallaby, Dr. Hamil, Dr. Davis, who's also in dialysis. Dr. Kakajwal is right here. You can call him Dr. K if you see him on the floor because his name's kind of hard to pronounce. And then our division director is Dr. Darnadarka. And then these are the nurse practitioners. Kathy's not with us anymore. We have a different nurse practitioner now in dialysis, but these are our outpatient nurses, Pat and Ruth. So when Dr. Barton was talking to you about the nephrotic syndrome patients, if they're admitted for the first time, a lot of the education is going to come from them. So you can always call the renal office, but most of the time the attendings on will give us a call, and then you'll get a call from either me or usually one of them, and we'll kind of schedule a time to come up and talk with the families. We have a whole packet that we go over with them because we teach them the Albu sticks. We teach them how to check their urine every day and when to call us. I have brought that packet, but I forgot it this morning. And then the dialysis team is down here, which you're going to meet them next. So just a general overview, development of the kidneys begins at week 5 of gestation and complete usually by 32 to 34 weeks. So all those early NICU babies don't have a whole lot of complete kidney function, so we follow a lot of them. But the kidneys are 2 bean-shaped structures. They're located in the retroperitoneum. The right kidney is slightly lower than the left, and we tell all of our kids who come into clinic they're about the size of their fist. So that's an easy way to kind of think of it. So how the kidney works, obviously the blood with the waste products comes in through the renal artery, gets filtered out, and then you make urine. Reabsorbing everything that, the electrolytes and everything that your body needs and getting rid of everything it didn't need. So what do? They remove and excrete waste products by filtering the blood. They balance the amount of fluids and electrolytes within the body. They release hormones that balance blood pressure. So in the outpatient world, a lot of our kids will get referred to us for high blood pressure. And you'd think they would typically go to cardiology, but they come to us because usually, we'll talk about it more, but more kids with high blood pressure can be from a secondary cause of injury from the kidneys or just something going on with the kidneys. They produce the active form of vitamin D to promote strong and healthy bones, and then they control the production of red blood cells via erythropoietin. So when Dr. Barton was saying we'll look at CBCs a lot in any patient that comes in with kidney injury, it's because the kidneys kind of control the amount of red blood cells there. So any kiddo that comes in just kind of in general with kidney disease or we're worried about their kidneys at all, we always get a renal ultrasound just to make sure they actually have 2 kidneys because sometimes they only have 1. We'll get a urinalysis. We'll look at the protein in their urine, the blood in their urine, and then just see if there's any infection. We'll get a protein to creatinine ratio, kind of we discussed earlier, but it should be less than 0.2 in children 2 years and older. We'll get a renal function panel, a CBC, and then we'll look at their blood pressure and their growth. So that's just kind of general renal overview just quickly. The next thing we'll talk about is glomerulonephritis, which you guys will see on the floors, which we kind of touched on a little bit, but kind of going further into it. So glomerulonephritis is a generalized term, more for a set of findings in a patient. So that includes blood in the urine, protein in the urine, they're going to have a lot of edema, and then most times hypertension. It can progress to renal failure. We don't fully understand what causes glomerulonephritis, but it's thought to be an immune system's response to something. There's injury and inflammation in the glomerulus, and it's caused by the complement activation. So you'll have leukocyte recruitment and then release of growth factors and cytokines. It can be limited to just the kidneys, or it can be part of a systemic disorder. So there's a couple classifications. It's confusing, even I don't even understand it all, but really these are just causes of glomerulonephritis. So I would say up top are more of the chronic things, and then on the bottom can be more acute, so the hemolytic uremic syndrome, the post-strep GN, so We don't see it as much anymore, but sometimes you'll get a kid who comes in with a history of, I had strep throat 2 weeks ago, and then they all of a sudden develop blood in their urine, and they come in for high blood pressure, blood in their urine, and they're really swollen. And or HSP, lupus. So these kind of top things like the post-strep, post-infectious GN, they just kind of have to run their course, and it's really supportive care, making sure their blood pressure is under control and they don't get too swollen. But it typically will end up fine without any type of dialysis or anything like that. So there's acute, chronic, and rapidly progressing. So acute is kind of that post-strep or the HSP, the HUS can have sudden onset of symptoms. They'll have decreased filtration rate. They'll hold on to a lot of sodium and water, so they'll be really swollen. They'll have hypertension. The chronic is often asymptomatic, and it just kind of progresses over a slow amount of time. And then rapidly progressing renal failure develops in over days to weeks. So those kids will be in quickly and all of a sudden go downhill real fast. So evaluation, obviously we'll get a urinalysis again. We'll look for blood and protein because it'll be there with these kids. We'll get a CBC. They'll probably have a slight anemia. RFP, their creatinine's probably going to be increased, and they may have other electrolyte disturbances. We'll look at their complement levels, so C3, C4. They both will be low in the setting of lupus. If only the C3 is low, that's associated more with like the post-strep GN picture. We'll look at ASO titers. That's kind of helpful to determine if it's post-strep or not. And then they'll get other studies. ANA, ANCA, that's more of looking at kind of like the autoimmune process and looking more for like vasculitis type picture. A biopsy, it's rarely initially done, but only if we can't really understand or piece together what's happening or what caused this in the patient. So here's a fun little picture of just what your patients may kind of be experiencing. So they may have headaches or be irritable, they'll have high blood pressure, have facial or periorbital edema, they may be tired, low-grade fevers, they'll have weight gain, so those daily INOs are important. And then they'll have protein in their urine, blood in their urine. They may not have it in the urine or may have some burning or discomfort whenever they do void. So if you have a patient with this on the floor, what do? It's just really supportive care. So no appropriate blood pressure measurements for the patients. So I think in kiddos, does it still flag you if the blood pressure is too high or too low? Okay. So know what the normal values are. If it's elevated, I would check it manually. And then you are concerned for these patients with hypertensive crisis. So really watch those blood pressures. Strict INO, possible daily weights if they're really edematous. And then just watch for decreased urine output. Assess for lung sounds and risk of respiratory distress with the edema. And then know that they may need some dietary restrictions, that renal diet. That's kind of tricky. Most of the time it's just sodium and fluid restriction, which should be in your order set. And then, of course, know how to contact the renal physician on for the shift and just let them know if there are any concerns. And you may have to teach them how to do blood pressures once they're close to being discharged. So if they have high blood pressure and they're started on antihypertensive, I would maybe start that process with the family. When I was on the floor, it was always like, they're going home at 5, let's do blood pressure teaching at 3. It's like, you can't teach someone to take blood pressures that shortly, especially in like a 3-year-old. That's a really hard skill to learn. So if you have questions, concerns, you can give us a call and we can come up and help too. And then no possible side effects of the medicine. So they may be on steroids, which may make them really irritable, more hungry, mood swings, or not going to sleep. Or if we put them on an antihypertensive, just know the blood pressure medicines like amlodipine, lisinopril, which we'll talk a little bit more about those. Questions? It's really fast.
Question.
Yeah.
So those going home with, we're teaching the parents to do their blood pressures. Will we supply a cuff before they go home? And that equipment so they can learn on their home?
So typically, I think that it's ordered through home health. They'll ask you for like an arm circumference measurement just to make sure we get the right size cuff for them. But if you let them know, then they should get one ordered And they may receive it before they leave the floor. They may get it shipped to their house. If they're babies, we'll try to order a Doppler, but I don't know if you guys will get a whole lot of those on the floor. So I would say just start the education process, and home health should order it. But if you have any problems or you can't get one, definitely give us a call in the outpatient office and we can see what we can do. Sometimes we write like letters of medical necessity saying they're going to die if they don't have this, and that's usually the only way we get them. So
yesterday, home health had ordered it. We had to teach them how to do it with our machines, and it was sent to their house, but we had to provide them with the stethoscope.
Okay, perfect. Yeah, and if anything, if you're having a parent who's really struggling, because to me that was one of the hardest things I learned in nursing school was like hearing that first beat, and then the second one. The automatic machines at like Walgreens and Walmart, they work pretty well now. Like they're pretty close. It's just making sure they find the right size cuff for the patient. So in the outpatient world, we do say those are fine to use. So moving on to that, so hypertension. So blood pressure is the amount of blood flow that your heart pumps and the amount of resistance to blood flow within your arteries. So the more blood your heart pumps and the narrower your arteries are, the higher blood pressure is going to be. So you know, in the adult world, we say 120/80. That's that kind of sweet spot. That's that good blood pressure. But in pediatrics, it's different because they don't have adult bodies. So we go off this kind of percentile according to the child's height and weight and their age. So I had that chart, and I didn't bring it with me this time, and I apologize. But if you kind of Google, or I'm sure they're on the floors, you can look and see, like if you have a 3-year-old, you find their height percentile. It's going to tell you what their 50th percentile blood pressure should be, their 90th, their 95th, and their 99th. So ideally, we want them 50th to 90th, somewhere around there, but they may be higher, and then they'll come see us. So pre-hypertension is kind of defined as systolic and or diastolic blood pressure greater than that 90th percentile, but less than the 95th. Or if their blood pressure exceeds 120/80. And then overt hypertension is defined as either systolic and or diastolic blood pressure greater than that 95th percentile measured. And then hypertension is further delineated into stage 1 and stage 2. So stage 1 is when the blood pressure is between the 95th percentile plus 5 millimeters mercury above the 99th percentile. It's kind of tricky. And then stage 2 is that if they're greater than the 99th percentile plus that 5 millimeters of mercury. So why would a child have hypertension? So a lot of the times, like I said, they come to us first because it was thought that if a child's having high blood pressure, there's something wrong with their kidneys that's causing that. So that's a secondary cause. So they may have narrow arteries to their kidneys, which is causing an increase in hormone release, which causes their blood pressure to be high. They may have problems with their thyroid. They may have another underlying renal disease, or they could have a rare tumor secreting catecholamine tumor, I guess, which we've had 2 of those in the last year, which they're very rare. So everyone's telling me that. I'm like, I've been here for 2 years and we've had like 3, I think. So I don't know how rare, but so that's why they come to us, just to make sure they don't have any of that wrong. Now, most of the time they do come just because of how our kids are growing up these days. It's usually related to their lifestyle. So it's usually primary hypertension where we can't find any other cause, which is a good thing because this is also lifestyle management and they can change it if they want. So obtaining a blood pressure, the most important thing that we tell our parents, and that I want you guys to remember too, is that it's really just making sure that the cuff is fitting right. So you want to make sure that it covers 2/3 of their upper arm and that the cuff goes all the way around and it's not too tight, not too loose. If you're getting high blood pressures on one cuff, I would try the next size up and just kind of see what kind of blood pressures you're getting, because you might get a better reading with the next size. We don't call that cheating. We say that's fine. And then there's Doppler blood pressure machines, which this video didn't work before, so I'm not going to try to pull up this time. But you guys have one of these on the floor, I think. If you have trouble using it, or usually when I was on 12, we'd use it a lot for one patient and everyone would get good at using it, and then you don't use it again for like 2 years because you just don't have the patients who need it. But basically, and these are also the blood pressure machines that like the infants will go home with. So typically those babies come from the NICU, but if for some reason you need help getting one because you're going to send one home on your floor with it, give us a call because we can come and do teaching with them on that too. So, but on this one, this is when you're not going to get that bottom number. You're just going to get that top, the systolic number. So the medications that these patients might be on, if they do have hypertension, or if they don't, they may be on an ACE inhibitor. So that's all the kind of medications that end in that pril. So lisinopril, enalapril, captopril. So this medication, like I said, if they don't have hypertension, they might be on this one of these medications too, because it does have renal protective properties, so it helps limit the amount of protein in the urine. So we may have that nephrotic syndrome patient who's really hard to get under control, and say if it ends up being something other than straightforward minimal change, they may be on an ACE inhibitor just to kind of help limit the amount of protein that they're leaking. We're kind of cautious with ACE inhibitors in the adolescent female because they are teratogenic, so we tell a lot of our teenagers in the outpatient world, when the time comes, far, far away, when you're ready to have a baby, just tell your doctor, they'll take you off of it, and then you can get pregnant, have your baby, and then go back on it. So side effects would be, some patients notice that they develop a dry cough. We had one patient who his parents swore he was smoking, and he was like, I'm not, and then we took him off the lisinopril. We put him on an ARB, losartan, and his cough went away. So he was getting in trouble all the time, and it was just his medicine. They may develop angioedema, so they'll have some swelling in their lips or their face, so that's not good. We'll switch them off that if they do develop that. And then we usually check blood work about 2 weeks after starting, and then at least yearly if they're doing okay on it, because it can cause some hyperkalemia, and then it also can cause a little bump in creatinine. So we just want to make sure it didn't bump their creatinine too much. A cousin to that medication is a angiotensin receptor blocker, so losartan or valsartan you'll see, and that basically is similar to an ACE inhibitor, but again, you don't see all those side effects. And then calcium channel blockers, that would be like amlodipine or Norvasc. This is probably our most prescribed medication that we use, especially in the primary hypertensive patients, because it's really low side effects. A lot of the world uses it for high blood pressure. Sometimes you'll see some headaches, sometimes you'll see some edema, but we don't have to monitor any blood work or anything like that, so it's really easy to use. Beta blockers are another class of antihypertensives, and we don't use those in asthmatic patients, but they are good in those patients who have migraines or are a little bit anxious sometimes. We just tell our kids with those that if they're exercising or they've been in gym class and they feel a little lightheaded, let us know, because it can cause some low heart rates. We usually just tell them increase their fluid intake, and they do pretty well. And then, of course, diuretics like water pills will work, but we do watch their potassium because that can drop a little bit. And then I feel like here more on the floors that you may see is clonidine, which can come in an oral form or patch. And I think that's all I have. Any questions? So here's our office number. You guys can call us if you have any concerns. It goes to the nurses, so just ask one of them, and if we don't know the answer, we'll try to find it for you.